Hey guys, welcome. So first of all, we're going to talk about the required PPE equipment. It's really important that you're wearing at least gloves, goggles, mask, perhaps even a face shield. Here's the mask here. And you're performing this type of procedure in a well ventilated area. For the sake of presentation, I will be presenting without a mask on. We're going to go through some basic airway positions and basic sort of patient management positions. First of all, you'll see that the patient is laying down supine with the end of the bed quite flat. This is a position that you'll generally find patients in, which is definitely not the most optimal or ideal position for their airway positioning. So what I like to do is come in and at least lift up the stretcher to about a 20 to 30 degree angle, unless there's a cervical injury, which will be contraindicated in that stage. Ideally, what I want to aim for is the fact that the ear canals are in line with the sternal notch, and this can be corrected in a sense by ramping underneath, or placing towels, pillows, blankets underneath the shoulders, underneath the neck and the head as well. Be aware that you might need to add a number of towels or blankets underneath the shoulders, the neck or the head of larger obese patients or those with the kyphosis. Avoid this technique in anyone suspected spinal cord injury. Refer to the neutral position. So what I'm generally aiming to do is get this in a quite a straight plane together, and also get the patient's face to run parallel with the roof. So I'm just going to do some ramping now. So I'm going to put some towels underneath the shoulders. I can look a little bit rough. Definitely get an assistant to help out during this procedure, and bringing the head right up too. So this is sort of the first step to getting a really good position for the patient and preparing you for any future airway maneuvers. You can see here that I've also raised the head end of the bed to about a 30 degree angle. This is going to improve our area for gas exchange. If there's any fluid in the lungs, it's now going to pull down around the basal area. It is also going to reduce and hopefully prevent any aspiration. The benefit of managing the patient in the supine position is the ability to be able to look and visualize the airway. It's also quite easy to maneuver their head and put their airway in a position that's going to optimize their ventilation. So I can do that quite simply by just moving their head up and down with my thumb over the forehead, protracting the jaw and pushing forward, which gives me access to look into the airway, and even just by lifting the end of the stretcher up and down. So I've got really great access to the patient's airway like this. It also puts me in a really great position where the patient's head is just in line with my xiphoid process. So from a manual handling perspective and OHS sort of safety perspective, I'm not overexerting myself, bending my back. One of the problems with managing a patient in a supine position is the risk of their tongue falling backwards and closing over the oropharynx, creating a snore, reducing airflow. In addition to, if they are to vomit, there's no real protection from any aspiration. So ensure that you have suction close by. You can see here that I've got a Yanker sucker and a soft suction catheter device just placed by the side of the patient's head on the left, and I can employ that at any time. If the patient was to vomit, with my partner, I'll be placing hands on the side here, either side of the patient's head, and performing a stable log roll, so that my partner will be over the other side, rolling to the right, and supporting the patient as they vomit. It's also a very good idea to have an anti-medic on board before placing a patient in this position. In summary, the positions that we're going to be using is head tilt, chin lift, and jaw thrust. It's indicated for any patient that requires some active airway management. Avoid using this technique, especially the head tilt, in any patient that you suspect might have a potential cervical injury. So to perform the procedure, first what we're going to do is place the patient in the sniffing position. So that is meaning that their face is parallel with the roof of the horizontal surface. Secondly, we're going to perform head tilt, so your dominant hand or undominant hand, left or right, it's up to you, on the forehead with the thumb pointing down, and the other hand lifting the chin From this position you can inspect the airway, see if there's any foreign bodies or anything that might need to be suctioned out. From this position we're going to move our thumbs over the top of the zygomas, our third, fourth, fifth fingers across the angle of the jaw, and we're going to protract the jaw. So when it comes to applying a face mask to a patient, what you want to ensure is that your equipment is ready to go. There's no leaks, there's no cuts or anything like that, abrasions in the mask. Its integrity is quite good. It's very important when you're placing the mask on the patient to bunch up the cheeks and roll the mask on as well. So how I like to grip it is create a C around the top of the mask, the base of the mask, and then with my 3 fingers, that's going to grip the corner and the edge of the mandible and pull the jaw into the mask as I push down my thumb and index finger. So I'm placing over the top of the nose and the mouth, holding a good seal here. It's quite even on both sides. With my 3 other fingers, they're placed underneath the mandible and the corner of the jaw, and they lift up. So I'm protracting the jaw at the same time that I'm pushing down, as you can see here, against the face. What I'm looking for when I ventilate immediately is any leak which is coming from the mask seal. So if I hear any leak, generally what I'll do is roll the mask and make sure that it's evenly firm on each side. It's quite common to have one side up, which is going to allow air out of that exposed side. So ensuring that it's evenly placed over the face, the nose, the mouth, and that you have even pressure all around. When performing bag valve mask ventilation, squeeze the bag down gently and allow it to refill. Roughly to the amount that you've estimated based on the patient's weight, mils per kilo, and the size of the bag that you're using as well. So providing a ventilation in the unconscious, non-breathing patient, what we're looking for is rise and fall of the chest. This is in addition to improving physiological signs. Keep in mind the rate that you want to achieve and stick to that rate, that depth of ventilation, and review the physiological parameters that you're aiming for. Be mindful that when you're ventilating, that it is a very task saturated activity, and it will require all your concentration to be able to perform it correctly. So avoid getting distracted. Very important to avoid overbagging a patient, either hyperventilating them or pushing down too hard on the bag, as this can create distension and pressure in the stomach and certainly lead to aspiration, which is what we need to avoid at absolutely all costs. If you're unable to feel like you're providing good ventilations, there's resistance or there's a leak or there's a snore, the first thing to do is reposition your mask. Make sure that that is in the correct position, you've got a good grip, that you're not fatigued through those hands. The next step is to recheck your patient's position, their airway, their head position, ensuring that that the head hasn't flexed forward or hyperextended, and it's in that parallel range with the ears to the sternal notch. So troubleshoot that area first before reaching for adjuncts if possible. If you're still finding that single-handed bag valve mask is not effective, you're not getting the desired outcome that you're looking for, you've done the basic airway positions, you've remaneuvered the head and the neck, etc., then it's imperative that you change to a two-handed bag valve mask technique. This will require the use of an assistant to squeeze the bag whilst you use your 2 hands, so creating a CW grip or on the other side of the mask where your fingers will go along the angle of the mandible, and just concentrating on getting a really even, good seal on the mask whilst an assistant provides the ventilation. The lateral position is another really good position for the patient that requires some active airway management. This type of position is more employed in those that are spontaneously breathing. You're not too worried about their ventilation, however they're in an altered to unconscious state and they're at a risk of vomiting. So there's your alcohol, drug overdose type patients. And clearly then they're not at risk of a cervical injury. If the patient is to vomit, hopefully it'll be going out through the side, rather than if they're on their back, they're going to fill up their airway and aspirate on it. And it's a very easy position to apply a bit of jaw thrust, so putting your fingers down along the corner of the mandible and just pushing the jaw forward. This will often alleviate the sound of a snore and be all that really needs to be applied in many situations.